Hello, everybody. My name is Vyom and I'm a student at the University of Texas at Dallas, interning in the lab of Dr. Albert Montillo at the UT Southwestern Medical Center. And today I'll be presenting prediction of individual progression rate in Parkinson's disease using clinical measures and biomechanical measures of gait and postural stability. So Parkinson's disease is a devastating neurodegenerative disease characterized by symptoms such as resting tremor, limb stiffness, and slowness of movement. It's the second most common neurodegenerative disorder after Alzheimer's disorder. And current treatments, such as dopaminergic drugs, while they alleviate symptoms, they are not cures. A major problem in developing disease-modifying therapies is that there's no clinically accepted method to predict individual progression rate. To highlight the difficulty of this problem, here I have a plot from our data set with x-axis as the time and y-axis as disease severity. And the red line is the average score for disease severity. And you can see while this average is going up across time, the individual patient scores, which are in gray, are very variable. And this heterogeneity across patients reflects the challenging nature of the problem. Our goal was to build a model that can predict individual progression rate and accurately identify fast progressors. This would not only allow informing patient decision-making and patient management with physicians, but also expedite the identification of a disease-modifying therapy. Obviously, drug trials are expensive, and the average total cost of developing a new drug is between $2 and $3 billion. And identifying fast progressors would allow the enrichment of clinical trials where the difference between placebo and a drug can be seen faster within the duration of the clinical trial in these fast progressors. Our dataset involved 160 PD subjects from the Parkinson's disease biomarkers program. These subjects were followed longitudinally for 2 years at UT Southwestern by Dr. Richard Dewey, our clinical collaborator. Disease severity was measured by the Movement Disorder Society revision of the Unified Parkinson's Disease Rating Scale, or the MDS-UPDRS. Here I have some demographics plotted with a histogram of ages for males in blue and females in orange. So our aim was to predict this MDS-UPDRS score, which is the MDS-UPDRS assessment is a 4-part assessment of PD severity conducted by a trained examiner. And we focused specifically on part 3, which was the motor examination, consisting of 18 sections, such as speech, facial expression, and gait. Here's an example section, which seeks to measure the severity of gait symptoms, rated 0 as normal to 4 as severe. These assessments were conducted while patients were on medication, and to eliminate rater bias as a confound, a single rater was used throughout the study for all subjects. We constructed 3 prediction targets for this study. One was the 2-year MDS-UPDRS Part 3 score. The second was 2 years minus baseline. And the third was 2 years minus baseline divided by baseline, or a % change in MDS-UPDRS Part 3 score. And these 3 were considered because each gives slightly different information about the disease progression and severity in future. Here I have a plot of the MDS-UPDRS Part 3 score, 2 years minus baseline, with in the y-axis, and the patients in the x-axis sorted by increasing amount of the score. And you can see how heterogeneous this is, again, across all subjects. And the scores have been labeled fast and slow progressors, with fast in green and slow in gray, split at the median. For our features, we examined previous literature, which found that gait and postural stability characteristics are associated with current PD risk, progression, and diagnosis. Here, for example, is a stabilogram plot from a previous study, which plots these sway postural instability measures, and you can see that visually the control subject has limited postural instability, while PD subjects with differing severities have significantly different patterns of postural sway from the control subject as well as between each other. So we obtained these biomechanical gait and postural stability measures using 6 movement sensors, which contained accelerometers, gyroscopes, and magnetometers placed at these locations. These sensors were the APDM Mobility Lab Opal sensors, and 2 mobility tests were conducted while the patients were on medication. The first task was the instrumented timed up and go, or ITUG test, where subjects start from a sitting position, stand up, walk 6 meters, turn 180 degrees, walk back to the chair, and sit down. And the second test was the instrumented sway, or I-sway test, where a subject stands still with their hands across their chests and feet positioned a set distance apart. And this is done for a set amount of time. Here I have an example video of the ITUG test, where you can see that the test captures various sections of getting up and turning and walking. And this gives measures such as stride length, step time variability, gait speed, foot clearance, and here we'll see we get trunk range of motion and arm range of motion. And these are just some examples of the measures that are extracted from the ITUG test. We also considered clinical and demographic features, which included age, gender, baseline MDS UPDRS Part 3 scores, libido by equivalent daily dose, and baseline Montreal Cognitive Assessment scores. We constructed some features from these baseline ITUG and I-sway measures and combined them in various ways. So we considered, just the baseline ITUG I-sway. We also considered a delta, so 6 months minus baseline, a change for those ITUG I-sway measures. We also computed an asymmetry score for some of the ITUG I-sway measures were lateralized, so they had left and right versions. And for those, we computed this asymmetry score with this formula of 1 minus left over right. And we also had the clinical measures and the asymmetry measures on just the ITUG I-sway and the 6 months minus baseline ITUG I-sway. So for the gait and postural stability measure feature sets, we had the baseline ITUG I-sway on their own with base G, delta G containing the 6 months minus baseline, asymmetric base G containing the 6 months minus baseline, containing the baseline ITUG I-sway asymmetry scores, AC delta G containing the asymmetric 6 months minus baseline ITUG I-sway scores, and all G containing all of these ITUG and I-sway measures combined. We also considered the clinical measures on their own, as well as in combination with all the ITUG I-sway measures. For our partitioning, we performed nested K-fold cross-validation with 3 inner and 3 outer folds. For model optimization, we selected XGBoost and feed-forward neural networks as the 2 model categories to test, and these 2 were selected because they've been shown to perform highly on structured and unstructured data. We performed hyperparameter optimization and model selection on inner folds using a random search algorithm. And this random search of hyperparameter space ensures an unbiased model tuning and model selection, which is largely independent of the experimenter's experience. Performance was evaluated using the R-squared score on held-out partitions. We also conducted a feature importance analysis using feature permutation importance, where each feature is randomly permuted 100 times, and the decrease in performance is measured to indicate the importance of that feature in making a successful prediction. So our results, here the rows have the different targets, the 3 different targets we considered, and the columns have the different feature sets that we considered, and the color of the results I'm about to show represents the mean R-squared on the held out test set. So here are all the best performance scores for each feature set and target combination. I want to highlight here the best model performance of 37%, explaining 37% of the variance in the target using just the clinical measures to predict the percent change MDS-UPDRS Part 3. And this is comparable to the 41% performance achieved by Latourelle, but that I want to emphasize was on the validation split, which is typically inflated, whereas our performance is on the health out test set data. Our model also achieved a positive predictive value of 71% in identifying fast progressors, which is significant. I also want to emphasize that 21% of the variance in the 2-year UPDRS Part 3 score was explained with just the biomechanical measures alone. And we believe this is the first study to show biomechanical measures to have prognostic value for predicting future severity using machine learning. Looking at our feature importance results, on the x-axis is the mean permutation feature importance score, which again is the drop in performance when that feature is permuted. The y-axis shows the different features, and here we'll look at the feature importance for the feature set, for the clinical feature set in predicting the percent change UPDRS Part 3. So we can see that the upper extremity, hand, neck, and the total MDS-UPDRS Part 3 scores ranked highest in predicting this target. Looking at the biomechanical measures that were important in the ALGE feature set for predicting the 2-year MDS-UPDRS Part 3 score, we can see that the 6 months minus baseline gait measures ranked highest here. So it indicates that this delta of change from baseline to 6 months in these gait measures is important for predicting this future 2-year disease severity. So a major strength of our paper is that this is a comparatively large data set with 160 subjects, and we perform rigorous nested cross-validation, which ensures that performance on the held out test set data best approximates generalization on real-world data. However, of course, this was a single data set, and replication on an independent data set would further confirm our findings. For our future work, we're considering critically examining these ITUG ISWAY measures, which were constructed from the sensor data using the APDM Mobility Lab software, and perhaps these engineered features lose some signal that could be used to boost predictive power. So we're considering analyzing the raw sensor data itself to boost predictive power. In conclusion, we demonstrate the potential to enrich clinical trials. Our best predictive model achieved a 71% positive predictive value in identifying fast progressors on held out test set data, which can be used to enrich and expedite clinical trials for identifying disease-modifying therapies. And we believe, again, that we're the first study to show the predictive power of biomechanical measures using machine learning. Thank you so much for watching my virtual talk. I would like to acknowledge my PI, Dr. Albert Montillo, and my fellow lab members, especially Kevin Yen, who worked closely with me on this, our clinical collaborators, Dr. Richard Dewey and Ms. Ashley Gerald, and the funding source for this study, and the funding sources for our lab. And if there are any questions or comments, please feel free to reach out to me at this email address. Thank you so much.